So, very good day to one and all. I'm Dr. Rohit Gopinath, and today I'll be talking about a very important topic, venous diseases, concentrating specifically on the lower limbs. Now, venous diseases, especially of those of the lower limb, are extremely important because they are encountered in surgical practice on a day-to-day basis. So, before we go on to the pathologies involving the veins of the lower limbs particularly, it is very much essential that we have a basic understanding regarding the anatomy of the veins of the lower limb. So, the veins of the lower limb, three in types we can say. So, one are a group of veins called the deep veins. So, deep veins are also called veins of conduit. They are called so because they carry the major amount of blood and enter into the systemic circulation, that is into the inferior vena cava. So, veins of conduit are mainly the tibial vein, the popliteal vein, femoral vein, which in turn proceeds on into the external iliac vein, common iliac vein, and into the IVC. So, the veins of conduit or deep veins of the lower limb are called veins of conduit, and it includes the tibial vein, popliteal, and the femoral veins. Along with these, you have certain veins which are called pumping veins. So, these pumping veins are basically sinusoids or small veins which are located within the muscles of the calf. So, these veins which are located within the muscles of the calf constitute what are called as the musculovenous pumps, also called as the peripheral heart. They are mainly located within the gastrocnemius and soleus. Superficial veins include the long saphenous vein, the short saphenous vein, the posterior arch vein of Leonardo, and the anterior arch vein. So, this is a diagrammatic representation of the venous drainage of the lower limb. So, you have the posterior tibial, anterior tibial vein, which corresponds to their corresponding arteries. So, they form the popliteal vein, which forms the femoral vein, and then it extends upwards as the external iliac vein. So, to these deep veins, you have these superficial veins entering. So, common superficial veins, like I told you, are the long saphenous vein, you have the short saphenous vein, along with that you have the posterior arch vein of Leonardo and the anterior arch vein. So, it is very essential that we have a basic understanding regarding the anatomical landmarks which depict the course of these superficial veins. And the most important superficial vein of the lower limb is the great saphenous vein. It is invariably the longest vein or longest superficial vein in the body. It extends from the medial aspect of the dorsal venous arch of foot and then upwards anterior to the medial malleoli. It extends on the anteromedial aspect of the leg, goes posteriorly behind the knee joint, then again courses anteriorly onto the anteromedial aspect of the thigh, ascends up, and then it enters into the femoral vein, or it drains into the femoral vein by penetrating the deep fascia or cribriform fascia as it's called. By penetrating it, it enters and drains into the femoral vein. So, you find that this area where it drains into the femoral vein is called the saphenofemoral junction, and this saphenofemoral junction is located around 3.5 centimeters below and lateral to the pubic tubercle. So, all these landmarks are very important because they are necessary to identify the vein, not only to get an IV access but also in the treatment of varicose veins. So, this is the course of a great saphenous vein. Short saphenous vein has a more variable course. So, you find that the short saphenous vein originates from the lateral aspect of the foot. The lateral marginal vein continues upwards as the small saphenous vein. It extends upwards along the posterior aspect of the leg, and then as it comes up into the popliteal fossa, it penetrates the deep fascia and drains into the popliteal vein. Now, this saphenopopliteal junction, or where the short saphenous vein drains into the popliteal vein, is variable in location. Unlike the saphenofemoral junction, which is located 3.5 centimeters below and lateral to the pubic tubercle, the saphenopopliteal vein can be located anywhere within the popliteal fossa. So, it can be located in the lower end of the popliteal fossa, the upper end of the popliteal fossa, or the mid portion of the popliteal fossa. It is variable in its location within the popliteal fossa, but of course it cannot extend beyond the popliteal fossa. So this makes identification of small saphenous vein varicosities or sapheno-popliteal junction incompetence very difficult because its location is so variable. So diagnosis of sapheno-popliteal incompetence by Doppler and managing it surgically is little difficult when compared to a saphenofemoral junction incompetence. Okay. So these are the basic points regarding the course of the two most important superficial veins of the lower limb. Now these veins have their own branches. So you have the great saphenous vein which has the following branches. It has you cannot call it a branch, you can call it a distributary. So you find that you have draining veins which drain into it, which are called communicating veins. So these communicating veins can be anterior accessory saphenous vein, posterior accessory saphenous vein, you have posterior branch of it, you have the anterior branch of the saphenous vein. The long saphenous vein and the short saphenous vein, you find that they have a lot of draining communicating veins. So the two most important communicating veins are the anterior accessory saphenous vein, which drains into the great saphenous vein, posterior accessory saphenous vein. With regard to the short saphenous vein, the most important communicating vein is the gastrocnemius vein. Now, like I said earlier, other than the superficial veins, you have perforator veins. So what are these perforator veins? The perforator veins connect the superficial to the deep veins. The flow of blood is always from the superficial veins to the deep veins, because you find that the deep veins tend to have a lower resistance lower pressures when compared to the superficial veins, and there is an intervening valve between them. So this valve ensures that there is only unidirectional flow of blood from the superficial to the deep vein. So other than the perforator veins, you also have communicating veins, like I said earlier. So these are anastomotic veins which would connect to superficial veins. So they are generally located within the subcutaneous plane. They do not penetrate the deep fascia, unlike the perforator veins which penetrates the deep fascia to drain into the deep veins. Communicating veins do not penetrate the deep fascia. There are two important communicating veins, named communicating veins, which play a very important role as far as varicose veins are concerned. So one of it is the long communicating vein between the great saphenous vein and the short saphenous vein. It's called the communicating vein of Giacometti-Cruvellea. So this communicating vein of Giacometti-Cruvellea connects the great saphenous vein with the short saphenous vein. Another important communicating vein is the anterior accessory great saphenous vein. So if you look at this picture, as I had marked this earlier, this is the anterior accessory great saphenous vein. So this anterior accessory saphenous vein, you find that it enters into the proximal portion, or just into the pre-terminal, or just before the saphenous vein penetrates the cribriform fascia and enters into the femoral vein. In that region, you have the anterior accessory saphenous vein opening. So this opening, like I said earlier, is very commonly just before it enters into the deep fascia. Sometimes it can directly open into the confluence between the great saphenous vein and the femoral vein, and very rarely, in 1% cases, it can open directly into the femoral vein. So you find that more often than not, in varicose veins, anterior accessory saphenous vein is the one which is more diseased. Anterior accessory saphenous vein is very important for another important reason. It receives a very important branch which is known as the superficial circumflex celiac superficial circumflex celiac vein, might drain into the anterior accessory saphenous vein. So you find that identifying this anterior accessory saphenous vein becomes very important, and it has to be tackled during surgery for varicose vein. So this here is a picture depicting a perforator vein which penetrates the deep fascia and connects the superficial vein to the deep veins, and it has valves which would ensure only unidirectional flow of blood from the superficial to the deep veins. Now perforator veins, you find that there are certain named perforators within the lower limb which carries significance because they can be diseased in varicose veins. So you find that these perforators can become incompetent, that would be the right terminology to be used, in varicose veins. So the named perforators, even though the number of perforators in the lower limb are many, named perforators are perforators involving the ankle joint, which are called as ankle perforators of May and Kussner. You have the lower leg perforators, which are called the Cockett's perforators 1, 2 and 3. And about 5 centimeters above the calcaneum, adjacent to the tender Achilles, we have the Bassis paraachillean perforator, which is again a named perforator, but it's usually missed. Then you have the below knee perforators of Boyd, the above knee perforators of Dodd, and the mid thigh perforator of Hunter's, or Hunterian perforator as it's called. Now, like I said earlier, the perforator veins have valves to ensure unidirectional flow of blood. Not only do the perforators have valves, even the superficial veins of the lower limb also have valves. So you find that the great saphenous vein has as many as 12 to 20 valves within it, ensuring unidirectional flow of blood, whereas the short saphenous vein can have around 8 to 10 valves. Now, the number of valves progressively decreases as the blood flows proximally. So, as the blood flows proximally, the number of valves tend to decrease, and there are no valves in the IVC. Now, it is very important to know about the physiology of venous blood flow in lower limb, because unlike other areas of the body, we have to remember that venous blood from the lower limb is always propelled against gravity. So there is a lot of physiology behind this venous return to the heart that occurs from the lower limb. Now, understanding the anatomy is very much essential to the treatment, identification and management of diseases of the veins of the lower limb. Understanding the physiology is required to identify the pathological processes which affect veins of the lower limb. So you find that veins are basically capacitance vessels. You find that veins are thin-walled, distend very easily, collect a lot of blood. Sometimes peripheral circulation or the superficial veins can collect up to 10% of the total blood in the lower limb. So these are capacitance vessels which carry a lot of blood or which store a lot of blood. So these, like I said earlier, are thin-walled, and when they are collapsed, they are elliptical, and when they are distended, they are oval in shape, or they are circular in shape. Spherical in shape would be better. So, because of this collapsible nature and distensible nature of veins, we find that the blood within the vein, flow of blood within the vein is dependent upon a lot of factors outside the venous wall. So, the factors which affect venous return to the heart from the lower limb are arterial pressure across the capillaries. So, you find that in a capillary, you find there is an arteriolar end and a venule end, arterial end and a venous end of a capillary. An arterial end of a capillary has a pressure as high as 32 millimeters of mercury, whereas the venous end, the pressures are half of that, 16 millimeters of mercury. This pressure difference ensures that blood travels quickly across the capillaries into the veins. So you find that the arterial pressure across the capillaries play a very important role in affecting venous return from the lower limb. Another important factor is the calf musculovenous pump. Like I said earlier, the venules or sinusoids located within the gastrocnemius and soleus, especially the gastrocnemius and soleus, play a very important role in pumping the blood proximally towards the heart. During an active phase of walking, the pressures in the calf can be as high as 200 to 300 millimeters of mercury. And during the resting phase, you find that the pressures are lower. And it is during the resting phase that blood enters from the superficial veins into the deep veins. And you find that at any given point of time, an average pressure, a normal pressure within the superficial veins at the level of the ankle is around 20 millimeters of mercury. So this pressure of 200 to 300 millimeters of mercury during active muscle contraction plays a very important role in propelling blood proximally into the major veins and subsequently to the foot pump mechanism. Again, plays an important role. Plantar plexus, foot plexus, you find that pressures in that region can help in propelling the blood proximally, venous blood proximally. Gravity also plays a very important role in affecting the venous return to the heart from the lower limb. So the factors responsible for venous return, again, like I said earlier, we've discussed about most of the factors responsible for venous return, but two very important factors which we need to concentrate on is the negative pressure within the thorax, which draws the venous blood from the lower limb, as well as the presence of non-reflexing valve. Coming on to the diseases involving the veins of the lower limb. The most important and the most deadly disease involving the veins of the lower limb, particularly deep veins of the lower limb, is the deep vein thrombosis. It's also called phlebothrombosis. It is characterized by the presence of a semi-solid clot within the deep veins of the leg, which breaks away over a period of time, creating embolisms, leading on to fatal pulmonary embolism and death. The most common vein which is involved initially, at least in deep vein thrombosis, is the soleal vein, from where it can proceed proximally to involve the other deep veins of the leg. For any thrombosis to occur, the classical triad of Virchow has to be fulfilled. So Virchow's triad includes: one is there is endothelial damage, there is hypercoagulability, as well as there is stasis. So these three factors are necessary for coagulation to occur. So these are called Virchow's triad. So any condition which can precipitate any one of these three factors are capable of causing deep vein thrombosis of the lower limb. So certain common causes are post-pregnancy, post-childbirth, trauma. Yes, when you have trauma, you can have injury, you can have clot formation. If you have a clot involving the vessels, it can again lead on to deep vein thrombosis. If you have injury, trauma can lead on to fractures or lower limb injuries, pelvic injuries, resulting in immobility. When you immobilize a patient for a long period of time, stasis tends to occur of blood in the lower limb. Stasis precipitates thrombosis. Oral contraceptive pills are notorious for causing deep vein thrombosis because it increases the viscosity. Visceral neoplasms, particularly pancreatic neoplasms, are known to precipitate deep vein thrombosis. Postoperative status. The most common cause for deep vein thrombosis is postoperative status. When you have postoperatively, a patient is forced to be immobile for long periods of time, it can itself precipitate a deep vein thrombosis. Polycythemia rubra vera increases the viscosity of blood, causing more stasis, resulting in deep vein thrombosis. Certain thrombogenic conditions like antithrombin 3, protein C, protein S deficiency, and factor 5 of Leiden deficiency can all lead on to thrombosis anywhere, but particularly in the lower limb, it can lead on to deep vein thrombosis. Now, we've been discussing about lower limb all this while. Now, while discussing about deep vein thrombosis, it is very essential that we discuss a variant of deep vein thrombosis involving the upper limb as well. So, in the upper limb, deep vein thrombosis commonly affects the axillary and the subclavian vein. So, this occurrence of deep vein thrombosis of the upper limb can be spontaneous or can occur following compression by a cervical rib, or following axillary nodal block dissection, or following keeping the arm abducted for prolonged periods of time. For example, like painting, brushing, etc., painting buildings and etc., when you keep the hand abducted for prolonged periods of time. Now, even though this is a possibility, axillary and subclavian vein thrombosis is documented, upper limb DVT or deep vein thrombosis is exceedingly rare. But the problem is more than 30% cases can result in a pulmonary embolism. So this here shows an image showing the impingement of the subclavian vein, by a cervical rib, causing stasis. There is an obstruction there. As a result of that, there is turbulent flow, there is endothelial damage, stasis precipitates thrombosis. So there is an entity called a Paget-Schroeter syndrome. So Paget-Schroeter syndrome is basically a primary upper limb DVT. So it is caused because of compression of the subclavian vein, resulting in a subclavian vein thrombosis. And this, as you can see here, this is an image which is depicting the presence of a subclavian vein thrombosis here because of compression of. Now, Unilateral limb swelling and discoloration pain are the most common features of upper limb DVT, particularly secondary to an axillary vein or a subclavian vein thrombosis. Another important feature is the presence of pitting edema, and sometimes we can have blisters as well. Diagnosis of upper limb DVT can be achieved by using a duplex scan or an MR venography. Treatment of upper limb DVT or deep vein thrombosis is similar to that of a lower limb DVT by using anticoagulants, elevation of the arm, compression stockings, etc. Now, there is an entity called thrombosis. So, thrombosis is deep vein thrombosis in people handling computers. So, this is a terminology which has recently come up, thrombosis. With regard to deep vein thrombosis of the lower limb, there are two terminologies that we need to be familiar with. One is phlegmasia alba dolens and phlegmasia caerulea dolens. So, this image here is a picture showing phlegmasia alba dolens. So, alba means white. So, this phlegmasia alba dolens is also called white leg. So, here there is a deep vein thrombosis of the femoral vein, resulting in painful congestion, edema and swelling of the lower limb. Associated with that, there is lymphangitis, resulting in even worsening of the edema of the limb. When you have severe edema of the limb, it precipitates as, or it appears as if the entire limb is white or blanched, giving the terminology phlegmasia alba dolens. Phlegmasia caerulea dolens, caerulea is colored, so it's red, but here you find that it is bluish, so it's also called blue leg. So phlegmasia caerulea dolens is also called blue leg. When you have a deep vein thrombosis of the iliac and pelvic veins, you find there is extensive venous stasis, venous gangrene and infarction associated with edema, giving the limb a bluish appearance, and hence it's called blue leg. What are the clinical features of a deep patient with a deep vein thrombosis of the lower limb? Fever is actually the earliest symptom of a patient with deep vein thrombosis of the lower limb. Swelling and pain can be noted of the calf and thigh. Sometimes the leg, if the calf is involved, you find that the leg may be tense, tender, warm, can be pale or bluish, like I said earlier, based on what type, whether it is alba dolens or caerulea dolens. There are certain classical signs with regard to DVT that we need to understand and remember. So, first one is a Hohmann sign. So, Hohmann sign is basically tenderness which is elicited or pain which is elicited on dorsiflexion of the foot when the knee is extended. So, in an extended knee, if you dorsiflex the foot, there will be severe pain at the level of the calf. So, this is called as Hohmann sign. Next is a Moses sign. So, Moses sign is wherein when you compress the calf, patient experiences very severe pain. Now, this sign is little precarious to elicit, because if you compress it too hard, you might induce an embolization. So, this compression should be pretty gentle, and it's also called Bancroft sign. Neuhoff sign is nothing but deep palpation of the calf muscles. You will be able to make out thickening and elicit tenderness on deep palpation of the calf muscles. So, that's called Neuhoff sign. So, other than this, the patient might present with features of pulmonary embolism. That could be the presenting feature. You may not even have any calf swelling or a leg swelling, but mainly might present with pulmonary embolism in the form of severe chest pain, cough, hemoptysis, breathlessness, etc. So, Linton's test is again a test which is done to look for the presence of any deep vein thrombosis. So, the common investigations which are used to diagnose deep vein thrombosis is a venous Doppler with duplex scanning. So, what are the classical features of the presence of a venous Doppler classical features of the presence of a deep vein thrombosis in a venous Doppler with duplex scanning? So, normally, like I said earlier, veins are collapsible. So, when you apply external pressure using a probe, usually the veins would collapse on itself. Sometimes these veins, if they don't collapse, then it would mean that there is something within the lumen preventing a collapse of the vein, most probably a thrombus. You might be able to make out an echogenic material within the vein, which again denotes the presence of a thrombus. But in cases where this echogenic material is not visualized in an ultrasound, in a Doppler, you might have to depend upon this compressibility test. And also, very important point to be remembered is that when you apply compression over the cuff, there is augmentation of venous flow. So absence of this augmentation of venous flow in a venous Doppler on compressing the cuff would mean that the venous flow is obstructed, possibly by a deep vein thrombosis. Another important point which can be taken as an indirect marker of the presence of a deep vein thrombosis is the absence of is that normally during inspiration there will be absence of a venous sound in the femoral vein. In the femoral vein, venous sound becomes absent during inspiration. So this absence of the venous sound during inspiration is not seen when you have a deep vein thrombosis involving the femoral vein. So the probe is placed on the femoral vein, and during inspiration there is absence of a venous sound. So this is conspicuously absent, or this phenomenon is not seen if there is an underlying thrombus. So other modalities which can be used to diagnose deep vein thrombosis are venograms, impedance plethysmography, radioactive iodine-125 fibrinogen study, etc. So what is a venogram? So a venogram is generally an anatomical mapping of the veins. So of the lower limb, it can be done in an invasive manner or in a non-invasive manner. So an invasive venogram can be an ascending venogram or can be a descending venogram. So you find that here the veins are cannulated and it's injected with a contrast medium, and filling defects are noted, and this filling defect invariably denotes the presence of a thrombus within the vein. Invasive procedures are now being discouraged to a large extent, particularly with regard to diagnosis. So we have now gone forward towards a CT venography or an MR venography. So this here is an MR venography, which is denoting the presence of a thrombus involving the left common iliac and external iliac vein. So we find that an MR venography is extremely sensitive and specific in identifying the presence of a venous thrombi, not only to detect the venous thrombi but also to identify the extent of the venous thrombi. And also it's non-invasive. There is no radiation in an MR venography. Another modality which can be used is an impedance plethysmography, which is used to denote the extent of venous flow or the rate of venous flow is identified by using an impedance plethysmography. So here what is done is that a cuff is applied at the level of the upper thigh and it is inflated. So it is inflated until you find there are no signals coming from the veins. This cuff is deflated all of a sudden, and you identify the rate of venous flow. If the rate of venous flow in a normal limb should ideally be very fast with a classical downward slope, whereas in the setting of a deep vein thrombosis, you find that this fall or this flow of venous blood will be very slow, will not have the classical drastic low curve or a downward curve. You will have a curve which is which slowly comes down or doesn't come down at all. So this would denote the presence of a thrombus within the deep vein. Another modality will be a radioactive iodine-125 fibrinogen study, like I said earlier. So here what is done is that we administer the patient 100 milligrams of sodium iodide 24 hours prior to the procedure. And after that you find that the person's administered on the day of procedure, the person's administered radioactive iodine-125 intravenously. And the baseline activity or baseline radiation levels are measured at the level of the heart. This is done pre-operatively, and then assessments are done at regular intervals in the post-operative period. You look for the presence of these assessments are done regularly in the post-operative periods in the lower limb from below upwards. So persistence of high radiation levels in the lower limb or accumulation of this iodine-125, radioactive iodine-125 in the lower limb in the post-operative period would denote the presence of a thrombus. Other blood investigations which can be done to detect or to identify the presence of a thrombi or a deep vein thrombosis is a D-dimer level and a hemogram with platelet count. A ventilation perfusion scan is mainly done in order to identify a pulmonary thromboembolism. It is more sensitive and specific in the detection of a pulmonary thromboembolism when compared to a CT angio, pulmonary CT angio, CT pulmonary angio. So, a ventilation perfusion scan is more sensitive and specific in detecting a pulmonary thromboembolic phenomenon when compared to a CT pulmonary angio. Now, what do you do if you identify that a person has a deep vein thrombosis? So, the management of a person with deep vein thrombosis mainly involves providing the patient with rest, because mobilizing the patient can result in dislodging of the clot, resulting in a thromboembolic phenomenon. Keeping the limb elevated, bandaging the entire limb. Use of anticoagulants are an integral component of the management of deep vein thrombosis. Commonly used anticoagulants are heparin, low molecular weight heparin, and warfarin. In deep vein thrombosis, there are two types of thrombosis that we can encounter. One would be a fixed thrombus, and another one would be a mobile. When you have a fixed thrombus, the management would involve provision of anticoagulants, namely heparin, at the rate of around 25,000 international units per day for 7 days. And during this period, the patient is monitored by looking at the APTT levels. Once heparin is given for 7 days, the patient should be shifted over to warfarin, which is an oral anticoagulant, and it should be provided for a period of at least 3 to 6 months. The dose of heparin is around 80 units per kilogram body weight, bolus. Sorry, over a chinna slide where the prachana irukku. So, how do you manage a case of deep vein thrombosis of the lower limb? So, the most important point to be remembered with regard to deep vein thrombosis of the lower limb is that the patient should be kept under complete rest, because mobilizing the patient can result in dislodgement of the thrombus, resulting in a thromboembolic phenomenon. The limb has to be kept elevated and has to be bandaged. Use of anticoagulants again is essential in the management of any case of deep vein thrombosis. Commonly used anticoagulants are heparin, low molecular weight heparin, and warfarin. With regard to a thrombus can be either a fixed thrombus or it can be a mobile thrombus. When you have a fixed thrombus, the treatment would involve provision of drugs, for example, like heparin, at a dosage of 25,000 international units per day for 7 days. After 7 days, the patient is shifted over to warfarin, has to be continued on warfarin for a period of 3 to 6 months. The dose of heparin which is administered generally is around 80 international units per kilogram body weight, bolus, followed by 15 units per kilogram body weight every day. Now, warfarin ideally has to be started simultaneous with the starting of heparin, and the patient should be discharged on warfarin. When the patient is being provided heparin during the initial period, the monitoring of the APTT should be done. Activated plasma tissue thromboplastin time has to be done in order to look for adequacy of heparinization. And once the patient has been shifted over to warfarin, then the investigation done to identify adequate anticoagulation is doing an INR. Warfarin is initially started at a dosage of around 10 milligrams on day 1 and day 2, and from day 3 it is shifted over to 5 milligrams. And because the onset of action, it takes some time for the onset of action of warfarin, it is generally started simultaneous with the starting of heparin. It has to be overlapped, basically that's what we are trying to say. So, the starting of warfarin should overlap the provision of heparin, and it has to be continued for a period of 3 to 6 months. And during this period, the INR, or the international normalized ratio, which is basically an assessment of the prothrombin time, should be kept between 2 to 3. And it is to be remembered that warfarin is absolutely contraindicated in pregnancy because of its teratogenic effects. So, during pregnancy, patients have to receive only heparin. Particularly low molecular weight heparin is much safer when compared to heparin itself, because the incidence of thrombocytopenia is very less with low molecular weight heparin, and low molecular weight heparin can be provided as a single day dose. If you have a free thrombus, then there is a role for fibrinolysins. So, the most commonly used fibrinolysin is a streptokinase. Streptokinase is administered at a dose of around 6 lakhs initially and then 1 lakh hourly. Along with streptokinase, you have urokinase, reptilase, and tissue plasminogen activators, which can also be administered. So, ideally streptokinase is administered directly into the affected vein. So, that is how we achieve an IV access, and then this fibrinolysin is directly administered into the affected vein. Other options available for a free thrombus is a venous thrombectomy, And then when you have a free thrombus, you should always remember there is a very high chance of embolization. So in order to prevent embolization of thrombi from the lower limb or wherever it is to the IVC and to the heart or to the pulmonary circulation, causing a pulmonary thromboembolism, there is a usage, we can use certain filters within the IVC. So to prevent this, the filters that are IVC filters that are commonly used are the Kim-Ray Greenfield filters, or we have a Mobin-Adin umbrella filter. So this here is a Kim-Ray Greenfield filter. So this is administered within the IVC, and this helps in preventing the thrombus or the emboli from reaching the pulmonary circulation and ending up in a pulmonary thromboembolism. So this here is a Mobin-Adin umbrella filter. So other options would be to use stapler plication or a suture sieve plication. Surgical procedures that can be done in the setting of deep vein thrombosis are only two. So one is a Palmer procedure and the second is a May-Husney procedure. So Palmer procedure is generally done for an iliofemoral thrombus. So when you have an iliofemoral thrombus wherein there is a thrombosis involving the external iliac vein and the proximal femoral vein, then in such cases what can be done is that the great saphenous vein of the opposite side is disconnected at its distal end and it is anastomosed to the femoral vein of the opposite limb. For example, if you have an iliofemoral thrombosis involving the left limb, like here, then the right great saphenous vein is disconnected from its origin at the level of the medial malleoli. It is brought and anastomosed to the femoral vein of the opposite of the diseased side. So the right great saphenous vein distal end is brought to the left side and anastomosed. So this procedure is called Palmer procedure. So it is done for a iliofemoral deep vein thrombosis. May-Husney procedure is another procedure which can be tried, which can be done if you have a popliteal thrombosis. So when you have a popliteal thrombosis, you find that popliteal thrombosis, what we can do is that the great saphenous vein of the diseased limb itself can be used to achieve venous drainage. So the distal end of the great saphenous vein of the affected limb is disconnected and it is anastomosed below the level of the thrombus. So if you have a thrombus here, okay, if you have a femoral thrombus or a proximal popliteal thrombus there, the great saphenous vein is disconnected from its distal end, brought up and anastomosed to the popliteal region, popliteal vein, creating a saphenopopliteal anastomosis. So this helps in draining the deep vessel, that is mainly from draining blood from the popliteal vein, and it drains it directly into the proximal femoral and then subsequently into the external iliac vein. So this is done in the case of a proximal popliteal or a femoral thrombosis. So there is something called a modified Well criteria for predicting pulmonary thromboembolism. So Well criteria includes the following important components. When you have clinical signs and symptoms of DVT, it has a score of 3. When there is no alternate diagnosis, again about 3 points is given. If the heart rate is more than 100 beats per minute, 1.5 score or points is given. If there is immobilization for more than 3 days duration or surgery in the previous 4 weeks, again 1.5 points is given. If there is previous history of pulmonary thromboembolism or a deep vein thrombosis, again a score of 1.5 is assigned. If there is hemoptysis, 1, malignancy with active treatment in the past 6 months, or the person is under palliative care, again a score of 1 is assigned. If the total score is more than 4, then there is a very high likelihood of a pulmonary thromboembolism. If the score is less than 4, then pulmonary thromboembolism is unlikely. So this is called a modified Well criteria for predicting pulmonary thromboembolism. So how do we prevent DVT? DVT is a condition which is best prevented because it is very difficult to treat. So the most important thing is to categorize any patient as a low risk, intermediate, moderate or a high risk patient. So a low risk patient is one who is less than 40 years of age and has undergone a procedure, say less than 30 minutes duration. Moderate risk is a patient more than 40 years of age and has undergone a long procedure but no comorbidities. When a patient has multiple comorbidities, including previous history of DVT, pulmonary thromboembolism, over the age of 40, debilitated, morbid, in such cases, that these patients have a high risk of developing a deep vein thrombosis. Prevention of deep vein thrombosis starts in the procedure, just before the procedure and during the procedure, just before the procedure. It is continued during the procedure and it is continued after the procedure as well. So, prevention of DVT can be achieved by using compression bandages, elevating the limb, stimulation of the calf muscles. So, this can be done during the operating procedure. Early mobilization also plays a very important role in the prevention of deep vein thrombosis. Use of low dose heparin, 5,000 international units subcutaneously 2 hours prior to the procedure can help in preventing DVT. So that's why I said prevention of DVT starts prior to the operating procedure. It is continued during the operating procedure and even after the operating procedure. So prior to the procedure, you can give heparin 5,000 international units 2 hours prior to it. During the procedure, we can give compression bandage or you can have pneumatic compression of the calf muscles during the procedure. Post procedure, again compression bandage can be continued, limb can be kept elevated, or there can be stimulation of the calf muscles. Use of dextran 70 also is said to play an important role to prevent DVT. 500 ml of dextran is given preoperatively and postoperatively, and that is said to play an important role in preventing deep vein thrombosis. OCPs, oral contraceptive pills, and estrogens should be stopped 6 to 8 weeks prior to any surgical procedure in order to reduce the risk of deep vein thrombosis. So, what is the sequel to a deep vein thrombosis? So, common sequel to a deep vein thrombosis is a pulmonary embolism. That can be seen in as high as around 10% cases. Infection and venous gangrene can occur. Partial recanalization of the pulmonary vein, partial recanalization of the deep vein can occur, resulting in increased pressures within the superficial veins, causing chronic venous insufficiency. Recurrent DVT is a possibility. There can be a prolongation of thrombus proximally.